Welcome to this webinar entitled Social Equity and Access to COVID-19 Vaccination. My name is El-Khatib. I am an epidemiologist by training and an associate professor in global health. But here I am in my capacity as the founder of the Facebook group called Epidemiologists. I would like to welcome four distinguished panelists: Dr. Peter Singer, Dr. Rana Haji, Dr. Anastasia Faris, and Dr. Nikolai Savaskan. Dr. Peter Singer is Special Advisor to the Director General and Assistant Director General of WHO. He is also Professor of Medicine at University of Toronto and co-founder of Grand Challenges Canada and the University of Toronto Joint Center for Bioethics. Dr. Rana Haji is a senior public health leader with over 27 years experience in global health, infectious diseases epidemiology, health policy and diplomacy, and health management, especially in the Middle East region. Dr. Haji is currently holding the position of the Director of Program Management at the WHO Eastern Mediterranean Regional Office since April 2019. Dr. Anastasia Faris is an infectious diseases epidemiologist working on scientific advice and risk assessments on COVID-19 at the European Center for Disease Prevention and Control, ECDC, since February 2020. Prior to that, Anastasia worked for more than 20 years on HIV, epidemiology, research policy, and clinical practice. Dr. Nikolai Savaskan is the head and Chief Medical Officer for the Department of Public Health, Neukölln, Berlin, Germany. More details about each panelist are shared below in the description of this video. I highly encourage the viewers to follow them on social media. I am personally thankful for them to be interactive in the public discourse around several topics in global health. For today's webinar, I have collected 5 questions in relation to the topic of social equity and access to COVID-19 vaccination. People posted very interesting questions from different parts of the world, so I will be showing 1 question per slide. Then each panelist will have the chance to answer the question. The format will be Q&A, which means there will be no follow-up questions unless if any panelist would like to elaborate more, of course. Also, I will leave it for the panelists to decide who would like to start first for each question. Also, yesterday, on Monday, the 21st February, we learned about the passing of Dr. Paul Farmer. Dr. Paul Farmer was a global health champion, professor at Harvard Medical School, anthropologist, and co-founder of Partners in Health. All of us, either we know of him or we know him personally. I was privileged personally to work under his team in Rwanda a few years ago, and it was a great honor to meet him in person as well. You feel his great love to people, social equity, and social justice. Paul will be greatly missed. I highly recommend reading his books, where the person will learn deeper about our challenges in global health and how we can contribute to the betterment of the world. Now, let us begin with the 5 questions. For the first question from Cameroon, how can social equity on the COVID vaccines coverage be implemented within African countries characterized with many enclaved areas? Who would like to take a stab on the start with it?
Ziad, I can start to say a few things, but with the caveat that, in my current job, I'm working in Europe and European Union. So although in the past, I have worked in Uganda and Zambia a bit, this isn't my current area for COVID, but I think that this applies beyond Africa. What I understand from the question is that looking at enclaved areas, meaning, difficulty in accessing maybe vaccination centers or sort of delivery of services. And this is a problem that exists outside of Africa as well, and exists beyond COVID as well. And so I think that this is something that we have always experienced in global health with regard to issues of, reaching populations that are harder to access, whether that be because of distance, transportation fees. We've seen this a lot in the HIV field, that, people coming to follow up and getting, maybe viral load testing or picking up medications has been a barrier for some populations. And there have been, community health outreach models. There have been models of giving more medication for longer periods of time. But for vaccination, I think that it's a bit the balance between delivery of a vaccine that can go out to rural areas and ensuring that there are structures that support that and vaccines that support that, and then good community work that's done in advance, so that once maybe mobile teams reach areas that are harder to access, that the community has already been sensitized and informed well in advance of what's happening. So those are some initial thoughts, again, with the caveat that this isn't an area that I'm working in presently. And so the other panelists may have much more experience.
Thanks, Anastasia. Rana, I think you are on mute.
I guess. Yes, you were saying this is one of the most common words.
Repeated sentence, as Peter.
You are on mute. Yes, thank you, Ziad, and good to be with you tonight or this morning. Maybe I would start just with a little preamble, because in our region, the Eastern Mediterranean, it covers 22 countries. 7 of the countries are actually in Africa per se, but mostly it is Northern and East Africa. And many of the African countries that are in our region include mainly low middle income countries, low income countries in particular. So when it came to access to COVID vaccines in particular, the issues, I think the issues that apply to many African countries were very much also issues that we have experienced in our region. And we suffered because many of these countries were actually the Gavi eligible countries, where they had significant limitations in the actual capacity of their vaccination program to start with. And this is just maybe to remind me later to talk about how important it was to strengthen the immunization platform altogether. In order to ensure better equity and better access to vaccines, because if we had that better established and really strong systems, we wouldn't have faced many of the issues we faced delivering COVID vaccines. But I'd like to highlight 2 major issues when it comes to social equity, to ensure social equity for COVID vaccines. So mainly it's the access, of course, to vaccination services overall. So I think Anastasia mentioned a little bit that, every eligible individual, of course, should have full access to these vaccines, regardless of race, gender, or wherever they are located. But in many of the countries in Africa, in particular, I guess what's referred to as enclaved areas, we need to have the right strategies to deal with many of these barriers. We have barriers like distance to service centers. We have sometimes barriers, especially with the migrants and refugees who don't have legal documents, therefore they're not registered officially, and they have had issues accessing some of these vaccines. Sometimes some of them have even fear of deportation if they show up to some of these centers, if they are not registered. There are social issues, many language issues, etc. The other important, I think, issue with access to vaccines is the access to information, because sometimes what we have found, and we've done surveys actually to look at acceptance for COVID-19 vaccinations. We did 2 surveys in our region, 2 rounds of surveys. What we are finding sometimes in many of these countries, especially countries where there's not adequate access to information, this has affected their ability to access the vaccine. So it's not just enough to have to make sure we have the services available at the vaccination center, because we worked really hard to make sure vaccines are available in these countries, but also to make sure people are adequately informed and have access to the information. I think for us, we are pushing in many, now one of our biggest agendas is to push for stronger universal, more broader universal health coverage, using primary healthcare as the platform really to improve universal health coverage. I mean, we need to make sure we have a strategy that addresses access both in healthcare settings or primary healthcare settings, as well as access within the community. So we have many of these countries that had mobilized, I think Anastasia mentioned the mobile team, for example, because some of these communities don't even have access to any physical place or center where they can get the vaccines. Over to you. Thank you.
Thank you. Nikolai or Peter, who would like to take over?
Go ahead, Nikolai.
Well, Peter, maybe it's more your domain. So please.
Okay.
Yeah.
Sure. Well, firstly, thank you very much for having me on, Ziad, on this terrific webcast. I'd like to reinforce your paying of homage to our dear friend, Paul Farmer. In particular, the social equity in this question is what he was all about. He had justice flowing in his veins. And so I really want to just pay tribute to him in these initial comments. And in that spirit, I think the pandemic has been an X-ray of our soul. I think the top three lessons have been equity, equity, equity. Today, we're talking about vaccine equity. And frankly, that's an issue on which the world has failed and failed miserably. We're talking about a cost of at least hundreds of thousands of deaths, I would say several million. There's no exact figure out there. We're talking about an opportunity of saving over 1 million people. There was a recent preprint if equitable rollout can be achieved. So the human cost of what we're talking about is unbelievably large, but it's not only an issue in human cost, it's also an issue in self-preservation, because the best way to make variance is to leave vaccine inequity. So this is a threat to everybody in the world. Dr. Tedros has enunciated a goal of every country vaccinating 70% of their population by July to try and remedy this failure in the world. And he was asked earlier this week by the President of the General Assembly whether this goal is achievable. And he said, of course it is, but we have a lot of work to do. And that is very much in the spirit of great leaders who have risen to great challenges, which is what this is. Nelson Mandela, for example, said, it always seems impossible until it's done. And that is what we're up against here. We're not making good progress against that goal. There are 27 countries which have not even vaccinated 10% of their population, and 78 countries that have not even vaccinated 40%, which means in the 10% category, not even all health workers have been vaccinated. And in the 40%, not even all vulnerable people have been vaccinated. So we're not on track. It's an incredibly important goal. Equity saves lives, and it's a way to end the emergency, the global emergency phase of the pandemic. And so this is a very important topic, Ziad, and I really want to reinforce the comments also of Anastasia, and also of my sister, Rana, and colleague and friend. She dealt very beautifully with a lot of the distribution side issues and the distribution bottlenecks. And in the subsequent questions, I'll focus in more also on the supply side issues, both of vaccines and of the supply of technology, which is the sustainable solution. But here, I just wanted to say what this is one of the most significant challenges in the world. It's an example of the equity challenges we face in COVID. The world is failing, continuing to fail. I just looked up 13% coverage in African countries as a whole, according to Our World in Data as of this moment. That's pitiful, pitiful. Almost 14 months into a vaccine rollout. It's unacceptable. It's cost probably over 1 million lives, and there's a remaining opportunity to save probably over 1 million lives in the future. So this is all about how we translate our values into practice, and it really causes one to question whether indeed we do love our neighbor like we love ourselves, and whether indeed we do think we're our brother and sister's keeper. So thank you for the opportunity to comment, and back to you, Ziad.
Thank you, Peter. Nikolai?
Well, I think Peter said everything as anesthesia and Irana. Maybe one particular point I think is important from a perspective of a community doctor is the vaccination inequality is something we need to make more aware, especially in countries where we have multiple access to vaccinations. And one of the things which really struggles me is that politicians, especially here in Germany, think that if we reach a high rate of vaccination within the population, then the pandemic ends. And I think this is a fundamental misunderstanding of what about the pandemic. And of course, the pandemic will not be end simply by the fact that Germany may get a vaccination rate of 80% or 90%. And that's something which has to do with the maybe Eurocentric perspective in general, that we think, well, if something is going wrong in our neighborhood, then we just need to fix it by pulling in vaccination vials. We need to invest into the accessibility for the people to do so, and then that's it. Whereas we know that especially Germans are the world champions in traveling around the world, are the first nation which will get back the virus once the holiday time is ending. So I guess that besides all the questions of the logistic, the accessibility, the persuasion and execution programs, what we really need to make clear is the pandemic is an issue we all will deal with till next year, and maybe longer if we are not able to solve the vaccination inequality. I think that's simply the point. And any politician who may raises his voice or her voice that here in Europe we will end the pandemic just by vaccination programs we are doing here now, doesn't say what is really going on.
Thank you, Nikolai. We move to question 2 from Iran. What evidence has the experience with vaccination in the current pandemic produced which could be used to prioritize vaccination of vulnerable people, regardless of nationality, and increase solidarity with marginalized populations? Who would like to take a stab on this?
I can start again, but I think
Sure,
I'll reflect a little bit on the experiences of COVID, but I think that this, I'm not sure the question could probably apply to other areas, but I think, what we did try to learn in a very rapid and sort of situation of evolving evidence with COVID was it was very clear early on that populations who are older and who had comorbidities were at greatest risk for severe outcomes and can continue to be so. And then, trying to look into the evidence as to, what other populations may be at greater risk. And what we saw, and I think we'll talk about in the next question, is here in Europe, a lot of people of migrant background had, sort of more severe effects of COVID or more likely to be hospitalized, et cetera. And so those populations needed more attention and needed to be prioritized with regard to the vaccine rollout. What was interesting, though, is that, in most places this happened at national level, and it could only happen in countries where there was a supply of vaccine. And so that, as Peter very eloquently already outlined, differed from the beginning and continues to differ now today, even when supply issues shouldn't be as big of a problem, but they remain so. And we're having a lot of discussions around, for example, should we be vaccinating children who we know don't have, in most cases, if the child doesn't have comorbidities, really do not have a risk at all. It's a very, very, very low risk of having any type of severe outcomes. Should we be prioritizing vaccination in those populations over vaccinating older adults in countries that have not yet been vaccinated, or healthcare workers in those settings? And so I think that while this has been a very difficult discussion and one where a lot of inequities have been highlighted, I think it's been also one of the first times that we've had this global discussion on this level, in real time, and where the press and where popular sort of my neighbors are having opinions on this. And so I think that, in the best case scenario, we can use this maybe for public health and for other vaccination issues, but also for other sort of health equity issues, to push that to the forefront in discussion globally, to look at that. The same would exist for cardiac medications, I suppose, and diabetes, interventions, and maybe CAT scans, and there are a myriad of ways that this would apply to health. And so that's maybe I think the opportunity that we have as a global health community in this. So I'll stop there. I'm curious to hear what the others have to say.
Maybe I can go next. It looks like we're going to follow the same order. We're setting into a certain order. Maybe just to add, it's a good start where Anastasia started. I think this. Really, as Peter mentioned earlier, this pandemic has taught us so much, and maybe it's, so many lessons were learned, and a lot of it about the way we deal with providing services in an equitable manner. Basically, we really failed. These are issues that we didn't take into account, despite all our discourse about saying that health is a human right and access to all medicines and other interventions is a universal right. So I think the pandemic has really brought the issue of equity, and I hope really sincerely that after the pandemic, we don't go into the usual cycle of what we call panic and neglect, where we get all excited and energized, and then you forget about it and go to work. It has definitely scarred us here in the region. So I hope we will really continue to build on the momentum and the many lessons learned. So that's really an introduction to say, though, that the issue of vulnerable population and marginalized populations is very critical to the Middle East or the Eastern Mediterranean region. I think many of you know that we are the region where over almost half of our countries are affected directly or indirectly by conflict, emergency, war, where we actually in the region, we have the largest proportion of refugees and migrants in the world. So our population in total is about 750 million, which is about 10% of the global population. But we actually have in the region about 50% of the global burden of refugees. So, so basically, to say that when this pandemic started, this was really for us like a nightmare. We were very concerned about the COVID pandemic exploding in refugee camps, in certain areas where there's a high concentration of migrants. And it did at the beginning. We did have in some of our countries focused outbreaks among migrant workers that were fortunately contained relatively quickly. But what I also wanted to say I mean, we are all epidemiologists, I guess, here in this forum. Vulnerable people is not just refugees and migrants and marginalized population. We struggled, and many of our low-income and low-middle-income countries struggled with what I would call people at high risk. I mean, that's how I would define vulnerable people in general in our countries, people at higher risk of getting sicker, because what we saw, actually, we didn't see that refugees per se were having much higher rates of, of the disease, but nonetheless, we were concerned that they need to have access to services if they get sick. But vulnerable people, like people with the comorbidities, for example, many of our countries did not even have good statistics on the size of their vulnerable populations. So I would say one of the big things we learned is the importance of strong data. Without good data, you cannot have equitable services, because you don't even know where are your vulnerable people located. Where is the concentration? What proportion of your population? For some of our countries, they could give us some statistics, but for many of them that have maybe migrants who are not registered, they could not fully define the population at risk. In addition to data, as you know, data on comorbidities is probably one of our weakest data when it comes to health information systems. So that's another, I think, very strong lesson, and something we need to move forward on in terms of having stronger health information systems and stronger data, so they can enable better decision making altogether and better access to the vulnerable population. And then the maybe the one quick thing, excuse me, would like to add that what we learned, and Peter mentioned that I talked mainly about the distribution. So it wasn't just access to vaccines that's important, it's access to vaccination. Access to the actual, because we worked really hard on with COVAX, day and night we had a lot of many of our countries had bilateral also negotiations with the companies, but it wasn't just access to vaccines per se, it's access to the whole vaccination platform that was also an important lesson of this pandemic. And as they say in French, it's raison de plus, another reason to actually strengthen the whole platform of delivery of these life-saving services. And that should go way beyond COVID, because we have, national immunization programs are some of the best, they've always been some of the best public health programs in many of these countries. And we are seeing difficulty with marginalized populations sometimes in reaching, or people who live in areas that are difficult to reach and accessing many of these services. So over to you.
Thank you. How is it, Peter or Nikolai? Do you want to follow the pattern, or do you want to break the pattern?
No, we want to break it. It's now Nikolai's turn.
Okay, all right.
Okay, thank you, Peter. Well, from a perspective of a more or less high-income country, I think that when it's regarding the vulnerable people, that we have to have in mind that these are including not only homeless people or people with history in refugees or marginalized people. I think we should consider also people in a lonely status, older people who have low income, and in general, as you know, as an epidemiologist, all the parameters show that in the end, when it comes to the health status, that the socioeconomic status as well as the educational status are the relevant parameters, which through all data we have on health are the main data which show that here we have the common pattern where what we have to tackle. So what we learn from the pandemic and from the vaccination programs here in Berlin is that, first of all, we need to get easy language information systems. We need to get on board people who act as multiplicators within the communities we want to reach, and that in combination then with vaccination on the spot, with the social programs unifying with those of health workers, are probably the best way to reach then those who haven't been reached with all these governmental programs. And it is clear that this is a very time-consuming and also a very much human resource consuming approach. And that is what we now realize, that when it comes to a situation where we have vaccinated more than 60–70% of the population, then the programs start to stuck. Why? Because now all the big programs we have had in the beginning of the vaccination programs do not reach those who have to be reached now. So, and then we have, especially here in Germany, the situation that we have strong social programs with a lot of well-educated street workers and with officers who are very much trained in assessing young people as well as older people and so on. And in the meantime, we have a health worker system which doesn't communicate with the social programs. These are completely two different budgets, two different politically ordered systems. And well, the ones, they have access to the people, and the other, they have the education, they have the training to bring on vaccines to the people, and they do not communicate. So this is one of the big problems we face now. And well, there are also not so strong voices raising for those people who have now to be reached. And this is what makes the work so difficult and so, I would say, so detailed. And, you know, in the end, it's a business where you have to knock on each door to reach the people. And that is something which doesn't fit into the big programs we have had in the beginning of the vaccination program. Okay, go ahead. Hand over to Peter.
Thanks, Nikolai. So, you know, I think what's useful here is to take the counterfactual of this question. If you wanted to deprioritize vaccination of vulnerable people and decrease solidarity with marginalized populations, what would you do? You'd just say, the pandemic is over. It's endemic. It's actually the best way to leave people behind and to disregard equity. And so I think it's really quite important to push back against that narrative and to channel the singer Lenny Kravitz, it ain't over till it's over. And it ain't over. Why ain't it over? We might be on the other side of the Omicron shoulder, but there's still a lot of people in hospital around the world. And so Omicron ain't quite over. And it's dangerous to assume that Omicron will be the last variant. So I'm sorry, it ain't over. And that's a very, very, very important message. And then to build upon the point on vaccination, you know, what should we be doing, if you will, on the other side of Omicron, waiting for the next variant, which is more likely than not to come? Well, the foundation of that is vaccination. We've talked about that. That has both distribution and supply issues. On the supply side, we have to supply vaccines, and that's COVAX, more than 1 billion vaccines supplied, $16 billion shortfall in the ACT Accelerator, amazingly, against $13 or $14 trillion of economic damage so far. It would supply both vaccines, but also, and vaccination, but also the local production, the sharing of technology, the intellectual property waiver, the CTAP and the medicines patent pool for voluntary licensing, and very importantly, the domestic local production mRNA technology transfer hubs, because that's the sustainable solution. That's the fishing as opposed to getting fish version of this. And so the foundation of what we should be doing is vaccination, not only sharing vaccines, but also sharing technology so countries can make vaccines themselves in the future, because we'll have vaccine inequity 2.0 as soon as there's a variant-specific vaccine, as soon as there's a new vaccine, as soon as there's a new variant. It'll just be the whole replay again, which we saw preview of with boosters. But in addition to vaccination, and here I'm channeling some of the points that Nikolai said, we need to, it has to be vaccines plus, because vaccines alone, especially the current vaccines, aren't enough to dampen down completely the transmission. So we need the public health and social measures, including a high quality, well-fitting masks, ventilation, the physical distancing, the limiting gatherings, the rapid tests, et cetera. We need the public health and social measures ramped up and ramped down according to community prevalence. We need the clinical pathways to save lives. And that's the drugs, the diagnostics, et cetera, especially for vulnerable people who are at high risk. We need the ongoing surveillance, including the genomic surveillance, and we should always pay tribute to the scientists in low and middle income countries, like the scientists in South Africa, who use genomic surveillance actually to identify Omicron and were punished for it. So we have to think about the perverse incentives for actually doing what the world needs people to do. And then now we have to learn lessons like equity. So, you know, I'm a bit tone deaf, so I won't hum the tune of "It's over, it ain't over till it's over," but it ain't over till it's over. And the best way to actually make sure that more vulnerable people die all around the world is to just say, it's over.
Thank you, Peter. We'll move to question 3. Is there any strategy for migrants vaccination at different levels? And this is from Jordan.
Maybe to break the cycle again, let's not be too traditional. Sure. It's maybe, and since the question is from Jordan and I commented on the importance of migrant populations in the region. So yeah, I mean, of course, maybe I would like to talk about migrants and refugees, because for us, both of them, I mean, these two populations are very important. There is, you know, actually countries, the way we were planning the whole process is through what we call the National Vaccine Deployment Plan. So every country had its own NVDP, and they were supposed to include the whole population, not just the citizens. So migrants and refugees were actually part of the National Vaccine Deployment Plan. And in most of our countries, all legally at least registered migrants and refugees had the same access as the population to the vaccines. I mean, we did face, we had small pockets in some countries of migrants who were illegal migrants or not registered. Those we were able to access some of them through the through some of the other partners and NGOs, you know, UNHCR, IOM, others who we are working with. Also, it's important to mention that COVAX, as part of the COVAX process plans, they left 5%, at least there's what we call the buffer, that was part of the COVAX strategy. 5% of the COVAX vaccine supplies were actually put aside or allocated on principle. They were allocated to the also to refugees and migrants. And this is in case these population, in case the countries could not deliver. We haven't, at least in our region, we haven't had to use the buffer so far. I'm not sure, maybe Peter can comment, but I'm not sure if it had to be used in other countries. So I think it's really, I think I'm glad to say, and that in most of at least our countries in the region, this was not an issue for us in terms of ensuring these migrants and refugees get the vaccination. You know, at least we couldn't also force it, though. That's the other thing. I mean, sometimes the acceptance to vaccines among certain populations of migrants and refugees was a bit lower sometimes than the overall population in certain countries. And I was just in Jordan, actually, for a mission not a long time ago. And we heard, I mean, we have some data to support that even among the migrants and the refugees, the acceptance to vaccine was higher among men because they needed the vaccine, since it was a prerequisite for getting access to public spaces, to work, etc., while it was less among women. And similarly, the coverage was actually less among women in some of these populations than men. So we still have issues we have to address, but overall, at least, this was one of the good things, that these populations were adequately accounted for. Over to you, thanks.
Thank you. I would like to mention that actually by accident, the title was, by some accident, is Dr. Mohammed Abu Khair. He's a colleague and dear friend of mine. So I just want to mention this. Thank you. Who would like to take the...
All I'll say is any friend of yours is a friend of ours.
Thank you.
And beyond that, I don't have anything to add to the excellent intervention of Rana. So I'll leave it at that to help us save time.
Okay. Thanks. The stage here.
I could add a little bit. Thank you, Rana, for all of the great comments you've had so far. We did, my colleagues at ECDC have worked on a specific report on vaccination in migrant populations, including refugees, in the EU context. And so we published that last June, and I can maybe share the link with Ziad to add to the group. But they looked at what countries had data on COVID and migrant and refugee populations, and a lot of countries didn't have any. And we know this from other infectious diseases as well, that often information is not collected, and then, as was mentioned previously, when we don't have the data, we can't track. But several countries did actually, especially a lot of the Nordic countries had quite good data on the burden of COVID in migrant populations, and found that the risk for COVID infection, migrants were disproportionately affected by COVID. So they were more represented in the COVID statistics than in sort of the population statistics, and that there was a higher risk of hospitalization, as well as higher risk of all-cause mortality during the peaks of COVID. And probably this was attributed to maybe higher occupational risk in some countries for some migrant groups, and maybe lower access to healthcare services, as well as maybe messaging in appropriate languages. So a lot of this was the pre-vaccine era, but not only, but it was trying to draw some conclusions on lessons learned then for vaccination. And we know this even before COVID, how important it is that there are, people who can provide messaging in correct languages, taking care of misinformation or other issues within the healthcare system where there may be a lack of trust in migrant populations, and there are many good reasons for this in many parts of the world, where the sort of lack of full faith that the information being given is correct, or that this will be a good thing for me and for my community. Those issues need to be addressed, and in many places there's quite long-standing issues of mistrust, and so that's quite important. And then having members of the affected community participate in the messaging, we know this as well. We've known this for a long time across public health, and that continues to be important for vaccination, for COVID, and for other infections. And so those were some of the sort of good practices that were brought forward, and we're trying to follow this going forward. We know that the uptake of COVID vaccination in many migrant communities across Europe is lower than in non-migrant communities, and this continues to be a challenge. And exactly as you said, Peter, and I fully agree that if we start saying it's over and we open up and we no longer sort of focus on public health and social measures, that these are the communities that will continue to be impacted and affected more than others within Europe, but also across the world. Thanks.
Actually, I would add a small caveat here regarding the misinformation part, that in Jordan, in the Zaatari camp with MFNET and the UNODC, we just published a paper where we did a relaunching for an app, vaccination app, that was initially funded by Grand Challenges Canada. And then the UNODC, they did the relaunching for it, where information about COVID-19 and COVID-19 vaccines were added to it. It meant to be for the children, but then the parents said that they trust the staff, they trust the clinics, they have access to the internet, but they don't know what information is trustworthy on the internet. So they said, can you please add information to the app So the UNODC was very kind to take this challenge and to relaunch the app by adding information on parenting skills to support parents and refugees during the COVID-19 and the stressful time. And also we used information from WHO and UNICEF around COVID-19 and COVID-19 vaccines as Q&A. So the parents were very happy about it, to be able to read information that are trustworthy, especially during this difficult time that even they cannot trust if this website is WHO for real or not. Imagine to what extent they are. So this was a small caveat from my side regarding this topic. So Nikolai, I think it's your turn.
Well, I cannot add anything to what has been said. So,
okay, let's move on. Question number 4. We all agree rich countries did not do enough to guarantee universal access to COVID-19 vaccines in 2021. But why were poorer countries in such a poor state to begin with? Why have vaccines and other basics of public health, clean water, sewage disposal not been on their own government's health agendas? All seem to have money for weapons, cavalcades, sports stadia, politician private jets, but are not held accountable for these most basic failings. How do we do better? So this is from South Africa.
Maybe I could just jump in. I think that this is one of the interesting things about COVID is it turns the so-called developing country thing on its head. There's a 200-fold, actually, sorry, 50 to 100-fold difference in cumulative mortality, even among G20 countries. And so, this is not about quote unquote rich countries, quote unquote poor countries. And in many cases, because of the muscle memory of vaccination and good leadership, certain low and middle income countries did much better than certain high income countries. And so I just want to push back on the kind of developing thing. And that takes us to the determinants of pandemic outcomes. And, there was really a brilliant paper published recently by Tom Boyke at the Council of Foreign Relations and his colleagues at the IHME that looked at that question. And what they found was the principal determinant of pandemic outcomes was actually trust. Trust in government, trust in each other. I mean, it's an incredibly important finding, which WHO is internalizing and will certainly implement in its universal health and periodic review, alongside other measures like IHR capacities and health systems capacities, by the way, which were not predictive of pandemic outcomes. I think it's not that they're not important, they're very important. They're table stakes. Those are necessary, but not sufficient, I think is what that data is showing us. And then we saw other types of outcomes like NCDs, obesity, diabetes, et cetera. And of course, age, as was mentioned before, really driving, especially the mortality aspect of pandemic outcomes. And so I think that the first thing to say about this question is to maybe push back a little on the rich country, poor country, developed country, developing country notion. And that, of course, leads us to 2 places, and I'll just mention them. We don't have the time to go into them in depth. One is the self-reliance of low and middle income countries. And that's why, for example, innovation and vaccine manufacturing are so important. They're a tool for self-reliance, as is strong leadership. Trust is a byproduct of leadership, by the way. So the self-reliance of low and middle income countries on the one hand, and the, shall we say, decolonizing, to use that word, maybe in quotation marks, of our approach to development assistance in high income countries, and to really think hard about the dependency that creates and how to push back against that dependency. And to come back to our beginning, and Paul Farmer, I mean, he was promoting liberation theology ideas in the context of equity. And that's all about power and self-reliance. So I think the whole thing fits together. I know Rana and Anastasia and Nikolai may have things to say about the specifics of this question, but I wanted to deal with the broader conceptualization, and it gets to the issue of solidarity, because the more we think of people as us and them, as ourselves and the other, those are the roots of inequity. Those are the roots of lack of solidarity. Frankly, those are the roots of colonialism. They're the roots of racism. And so what's at the heart of it is to go back to, do we really love our neighbor? And who do we consider to be our neighbor? And what do we mean by love? And how does love lead to justice? I mean, I'm sorry to sound corny, but it's these fundamental questions of values and how we translate them into practice that are the most fundamental learnings of vaccines, at COVID, and what we've gone through together in the last 2 years.
Thank you, Peter. I know that we're almost running out of time, but we still have one more question. Maybe I can run it also the question number 5, because I think there is some overlap between them. Is it okay? Okay. Equitable global access. This is from Uganda. Equitable global access to COVID-19 vaccines is important in improving social equity in the world. However, COVID-19 vaccination rates in low and middle income countries are far lower than desired. There has been a push that developed countries should share vaccines and the technology to make COVID-19 vaccines with low and middle income countries. However, little has been discussed on the role and responsibility of low and middle income countries in scaling up COVID-19 vaccinations. What role should low and middle income countries be playing in pushing the agenda for improving social equity and COVID-19 vaccination in their own countries?
Maybe Ziad, I can start with this one because it links, as you mentioned, to the previous question a little bit. And I think there's this perception that we are maybe making it easy for the low and the middle income countries not to be responsible for improving social equity. On the contrary, actually, the messages that we are repeating nonstop have been the same messages. Peter mentioned some of them. I mean, we keep encouraging countries to improve access to vaccinations for all their populations. We keep, repeating some of the lessons learned. What we have seen, that political commitment overall. I mean, actually, one of the most common lesson, even from the very recent reviews by the various committees that we have at WHO that reviewed the COVID response, 40% of the recommendations and the lessons learned focused on the importance of leadership and the importance of government ownership and good governance. And this was regardless of the actual, whether they are poor or rich or low income or low middle income countries. Because we have examples almost from all of these categories of countries that when you have strong political commitment in terms of managing the response overall is when we have seen the best outcomes. Noting that really all countries struggled, and what we have discovered overall that as a global community we were not well prepared for this pandemic. With regards to, two things I'd like to comment on. With regards to the countries encouraging vaccination, I think maybe the countries that did better are countries that, regardless again of the socioeconomic status, they were countries that had better community engagement. For example, in our region, we have Tunisia that has introduced a few years back this whole concept of dialogue sociétal, or basically a societal dialogue or collaborative governance. And they had a much better interaction with the community in terms of getting a better feel on what are the barriers to vaccinations, or the barriers even to the implementation of the other public health and social measures than others. So again, the issue is not income per se, but also the whole concept of better health governance overall and better ownership of the decision-making process. And the one thing, at least in our region, it was a wake-up call for countries in particular, or actually even for the high-income countries, to become less dependent in terms of vaccine production. We, in our region, for example, we used to have much, many more or much higher level of vaccine production 20 years ago. I'm talking about the, routine immunization vaccines. We had many vaccine manufacturers in the region at the national level, and for some reason they let this capacity fall through the cracks. And the last couple of years, we've seen a major increase in interest, a major increase in countries willing to improve their not just vaccine production, but all the infrastructure that goes with it, the regulatory capacity, the quality control, all the processes. So this has led to many countries actually asking to have the technology transfer for like mRNA techniques and others. And you heard DG, Dr. Tedros, late last week, during the weekend, there was an announcement about multiple countries in Africa that were now added as regional centers for mRNA vaccine production. In our region, we had Egypt and Tunisia, and there are a couple of other countries actually coming up outside Africa and our region and the rest of the world. So actually, this is a huge development. By the way, I mean, I didn't expect. I think very few of us expected such a rapid, or such an accelerated process in terms of improving vaccine production, and that by itself, I mean, I have to say, not to brag, WHO put a lot of effort into supporting countries to do that, but also that whole concept of solidarity, issues about the technology transfer and the difficulties we got from some of the technology owners to transfer it. This raised many issues. Again, I mean, some of the same lessons that we learned maybe 20 years ago when we were talking about making HIV medications available to low-income countries, we are relearning again, unfortunately, with vaccines. So they're definitely. I hope we take stock of many of these lessons this time, so we don't have to reinvent the wheel with the next pandemic or whatever the next crisis we have. So thank you. Over to you.
Thank you, Rana. Anyone would like to?
I just want to salute and applaud both the comments from Peter and Rana. They were fantastic, and I fully agree. So I don't have much more to add, but these messages are so important.
Yeah, the same from my side. I think Peter did say everything what answers the question. Maybe it's in the middle of a pandemic, also a little bit too much deceptive to now start to go into the analysis of what are the social equity in the middle of the pandemic. And I think what's sad is that we have something with we have to do with a virus which doesn't know any borders, and so the response to the virus should be also in the same way. So our answers to how to deal with the situation is that we leave our borders behind and think about regional or national strategies and responses. And that is what we even didn't make well within Europe, actually. I mean, if you recall the situation of the first wave or the second wave, that was a game of nations within their own topics. And I think the question is a good one, but you can skip the low and middle income point, because it's the situation we have to face, and we faced already within all three, and now even in the fourth wave. So I guess that the responses to a situation which is caused by a virus which doesn't respect borders is that we have also then take solutions to account which also work without boundaries and borders.
Great. And maybe I'll just come in very briefly to support the comments of Anastasia, Nikolai, and Rana, and Ziad. I liked your example too of that app. I just want to say, something about WHO and the world. And we've talked indirectly about the importance of. I think how we've talked indirectly about some of the things that WHO supports in the world. I think, for example, in leadership, Dr. Tedros has been the world's clearest advocate and conscience for equity and vaccine equity. I think in terms of support of countries, which is at the essence of WHO, Rana has spoken beautifully in the EMRA region. Of course, it applies around the world about how the 152 country offices support countries and actually help them to save lives. I think we've talked indirectly about the global goods of WHO. We wouldn't have the 10 vaccines or whatever around the world without the 10 emergency use listings. And that's vaccines and different types of facilities is how you get to the 10 number, 9 or 10. And then, of course, the mRNA hubs, the CTAP, all those global goods. But what I want to talk about is something a little bit more fundamental because it relates to the points that everyone was making. And that's the issue of governance. One of the most significant assets of WHO, which is both the member states and the Secretariat, is 194 member states, is its governance platform, inclusive governance. And so when you think about all the things we're talking about, equity and pandemic preparedness, there's no way to achieve any of them if you're not sitting on a platform of inclusive governance where every government or every country in the world has a say. And that, at the end of the day, might be the strongest asset of WHO to achieve social equity in vaccines, which is the topic of our conversation here, and in the right to health and in the recovery to the SDGs, because we're way behind on sustainable development goals. The shortfall in universal health coverage, for example, in universal health coverage billion is up to 840 million now out of the billion. The shortfall, so the progress is less than 20%. I mean, we need to massively accelerate to get back on track to the SDGs. That requires all the things we talked about, and it requires fundamentally the inclusion of the voice of every country in the world, because a pandemic can start anywhere and it needs to be stopped everywhere. So I just wanted to add that perspective on the kind of how I think what I've come to learn over the last couple of years of the fundamental value of WHO in supporting a healthier, fair, and safer world.
Thank you so much, everyone. So Anastasia, I think you said you will share a reference that we can post, correct?
Yes, I will do that.
Yep. Okay. And I will share also the reference for the paper for the app, the Children Immunization app, CIMA is called. Thank you so much, everyone. I really appreciate your time and all sharing also all your expertise and knowledge over these questions. Sorry.